আমারটা আসলে
এখনো দেখা যাচ্ছে না। এটা ওয়াইড করে দাও, ফুল স্ক্রিন করে দাও।
আমাকে দেখতে পাচ্ছেন? আজাদ দেখতে পাচ্ছেন?
আর দেখা যাচ্ছে স্যার, দেখা যাচ্ছে
ফুল স্ক্রিনে?
ফুল স্ক্রিনে দেখা যাচ্ছে স্যার।
তাহলে শহীদ ভাই কিছু একটা যে আপনার একটু ঠিক করে নেন বোধহয় আপনি।
দাঁড়াও, হ্যাঁ হ্যাঁ হ্যাঁ, এখন আসছে।
আচ্ছা আচ্ছা, ঠিক আছে ঠিক আছে।
হ্যাঁ, ঠিক করে নিয়েছি, এখন
আচ্ছা
আসছে।
ঠিক আছে। First of all, I would like to thank the organizer of Postgraduate Surgery Academia for giving me the chance to share my experience in this feast of knowledge, that is this gathering, particularly for our student, because once upon a time endoscopy was totally confined to gastroenterology, but now it has been incorporated in our course curriculum. United States, UK, everywhere it is mandatory endoscopy, and gradually we are approaching toward that arena. And particularly, we are, as a surgeon, we are interested for intervention. And this is my motto of that is spreading the knowledge among all the surgeons. So our gastrology started, actually ERCP started first in formally in 1994 or 1974, and our country after 30 years our gastrology started it. But fortunately after only 10 to 12 years later we started ERCP, then IPJ, then BSMMU, and we started in 2003 at the present Bangladesh Medical University. So today's presentation, actually I will give just a brief overview of ERCP, but because it is not possible to cover all the aspect of ERCP, those points which will be necessary for our student, that is who will appear in the postgrad exam, particularly in the hospital station and other places, you will have some images and you have to interpret it and you have to write answers. So I think that it will be helpful for the students only. I'm not going in details in every slide. So ERCP. ERCP first, in our question and answer session, it was mentioned. First, it started the diagnostic technique, and now this diagnostic part of ERCP, now it is purely a therapeutic procedure. That is, it is one of the form of minimally invasive surgery. This diagnostic part has totally been replaced by MRCP and endoscopic ultrasound. So we don't do any ERCP for diagnostic purpose nowadays. It is the most complex endoscopic procedure. Why complex? Because it is a as you see, there is endoscopic procedure, but some of the grave complication happens with ERCP. Even there is some chance of mortality in post ERCP complications. So this is a very complex, I should say, complex procedure. One should be very familiar with the procedure before going to start these procedures. And it has got potential for benefits. Definitely, I'll show what are the benefits. And there is definitely totally a instrumental procedure. You are doing intervention with a flexible endoscope. In laparoscopy, we do it at a rigid endoscope. All instruments are rigid, but here everything is flexible. It is beyond your control sometimes. So there is chance of failure, and if you fail, their adverse effect is inevitable. And lastly, medical legal issue is very important here, because you are going to do a endoscopic stone extraction, a benign disease. But if God forbid, if anything happens like pancreatitis, the patient might die. So nobody is going to accept these sorts of complications after doing this endoscopic intervention. So who want to do ERCP or who intend to start this procedure must be very careful about this medical legal issue. For a malignant patient, you can counsel the patient, but for a benign disease, if anything happens, it is very difficult to make the patient understand the complication of ERCP. So let's start with the for a safe, effective, and comfortable ERCP. I have divided this whole talk into 4 headlines. That is, what are the indications of ERCP, what are the contraindications, where we should not do it, and possible complications and limitations. That is, if something happens, what to do. Now, indications. The indication, you will in the different textbook, you will find the indication they have narrated in different ways. But as such, This five headlines include everything. Bile duct stone, biliary obstruction. Bile duct stone are different types: so primary, secondary, residual, recurrent. We name it in a different way, but I'll make it clear to everybody. Biliary obstruction may be benign or malignant. Bile duct injury is the issue, and another issue is biliary ascaris, because some part of our country is I should say endemic, or there is ascaric problem is there. So it is a problem for that particular area in Bangladesh. And last of all, pancreatitis. So let's start with if see there contraindication. There is absolute contraindication, that is unstable patient, recent myocardial infarction, severe COPD. There are certain patient is medically not stable, so you got to go for ERCP. Patient if the patient doesn't want ERCP, you can do it. And endoscopy with inadequate training on ERCP, because this is the area where you cannot start ERCP without any adequate training. Because in laparoscopy you can do it, you can do part of laparoscopy, your senior will complete the procedure. There is no way. In laparoscopy, if you fail, there is every option of conversion. But ERCP, you fail, if there is nobody by your side, that becomes a disaster. So relative contraindications these are relative, I should say, because somebody can do it in this condition also. There is portal hypertension causing coagulopathy, ascites, patient with acute pancreatitis. Acute pancreatitis is really condition, but in one condition, it is gallstone pancreatitis. You can do ERCP. You should do ERCP. Recent MI, severe pulmonary cardiopulmonary diseases, unless it is life-threatening, there is severe cholangitis, you have to take the risk. And repeated failed attempt of ERCP, when there is alternative procedure, alternative things are available. Anatomical alteration, but this I should say, after partial gastrectomy or surgical alteration, there are some conditions where actually it is very difficult to do ERCP with the conventional instruments. Preparation for ERCP for the students, you should remember one thing: ERCP is a surgery. Though it is a minimal invasive surgery, you must think to prepare the patient as that of a patient of open surgery, because the way you prepare a patient for open surgery, ERCP preparation is the same. There is nothing, because this is intervention. We are going to intervene somewhere, and if anything happens, we have to go for laparotomy. So keeping in the mind, there is a chance of there is a possibility of laparotomy or intervene other things if anything happens. So prepare the patient like that of the big surgery or open surgery. Like 1 week before ERCP, adjust the dose of medication and stop some speed. You know better than me that you have to stop the blood thinner and everything. You have to modify, that is oral hypoglycemic to that is soluble insulin. These are the very important things. You know it. Day before ERCP, complete all investigation needed for general anesthesia. And day of ERCP, some medication you have to take. Say for example, antihypertensive drug in the morning. That is thyroxine or other replacement therapy. You can take it in the morning with sips of water, and you should not take even water 6 to 8 hours before this procedure, because if anything remains in the stomach, there may be chance of aspiration. So preparation is as same as that of the open surgery. Nothing new. Let's start with the bile duct stone. Bile duct stone may be primary, secondary. And another area is bile duct stone is residual stone. Residual, I have included two conditions, that is retained stone and recurrent stone. Both, if you combine these two entities in a single headline, we can say it is residual, because this retained and recurrent is a confusion. That is the confusing term, because somebody has done gallbladder operation, and this stone has been detected after 5 years. And the stone was there during the gallbladder surgery, it was in the bile duct. So some will say it is recurrent, but actually it is a retained stone. So forget about this confusion. All stone, even after cholecystectomy, is residual stone. And as you know, this bile duct stone is the most common problem in the health system. And as a surgeon, we can provide on-stop management of this problem. We can go for gallbladder surgeon or gallbladder surgery, we can go for CVD stone extraction by doing ERCP. So the patient doesn't have to move from one specialty to another specialty, from one hospital to another hospital, from surgeon to gastroenterologist surgeon. So with the surgeon, we can provide one-stop management for bile duct stone disease, not that is gallstone disease, wherever may be the stones. And ERCP is the gold standard nowadays for CVD stone. Let's come to another issue, that is nowadays we get a stone, the patient having gallstone, there is 10% possibility of the coexistent stone in the bile ducts, and it increases this incidence, this frequency increases with age. That is, more the age, there will be more chance of, even some of the literature it has been said that to 20 to 30% possibility of concomitant stones. So predisposing factor we know. I'm not going to give details about that. So whatever may be the size of the stone, whatever may be the color of the stone, it is possible to extract it by doing ERCP. So I'll show some video clips for our students, just to encourage them, so that they feel interested in this aspect. This is, you see that there is simple stone. There's just simple papillotomy extraction is possible, but sometimes you see there is a big stone, more than 1.5 centimeter. We say that standard, but it is about 2.5 centimeter. Even you can do it with the help of ERCP. So it is not the size, it is the diameter of the bile duct till the papilla, that is ampulla better, that determines the result of ERCP. So you must remember, there are 100% cases it is not possible to remove all the stone. These are called, we call it difficult stones, because whenever you are going to attempt an ERCP, you must read the MRCP, and you have to see the caliber of the bile duct, the lower segment of the bile duct, everything you have to look for before venturing ERCP. So size of the stone more than 1.5 centimeter, multiple stone. The bile duct is full of stone. There is no space where you can open your basket, so it is not possible. Periampular diverticulum, it is a very challenging case for the beginners, because periampular diverticulum, sometimes this ampullary opening remains inside the ampulla, there in the one of the border or margin of the diverticulum, or inside the floor of the diverticulum. So here you cannot go for pre-cut, and it is very dangerous. If you do something excess, there is chance of perforation. Sometimes impacted stone, that is normal, but stone is impacted in a secular dilatation in the bile duct. It is not possible. Another thing I have mentioned that this narrowing of the distal, narrowing of the bile duct distal to the stone. What we call it? We call it as disproportion. That is disproportion between the size of the stone and caliber of the lower. Even it is a 5 millimeter at a 1 centimeter stone. 1 centimeter stone, it is possible, but sometimes the lower bile duct is 5 millimeter in caliber, or lower half of the CVD, but you cannot do it until and unless you go for lithotripsy. And another entity is angled CVD. This is not for our student, but we face this problem. Sometimes biliary dyskinesia, angulated bile duct, grossly dilated, it sometimes creates a problem for extraction. So what is the solution for this difficult stone? Big stone, the impacted stone, there is solution. You cannot sphincterotomy, you cannot do biliary sphincter. More than that, you cannot divide. So you cannot divide the common ampulla, but you cannot divide the that is the sphincter. So there is a way you can dilate the sphincter. That is what we call it, balloon sphincteroplasty. After incorporation of this technique, this is the balloon. We inflated the balloon in the after doing limited papillotomy, and then it is possible to remove all the stones. But initially it did not have been possible, but now after the introduction of the sphincteroplasty, it is possible. And here you can see we big a stone inside the bile duct. Lower end is very narrow. You see, lower end is very narrow, but this stone you can remove it by crushing inside the bile duct. These are the lithotripsy basket. This is called extracorporeal shockwave lithotripsy. No, this is the mechanical. Sorry, shockwave lithotripsy we don't use for bile duct stone. We use for pancreatic stone. This is for mechanical lithotripsy. Another lithotripsy is available, possible, that is laser lithotripsy. I am going to start this laser lithotripsy very soon. We have got the instrument. Other than core failure, I have already mentioned that is disproportion, multiple impacted stone, location of the ampulla, Hepatocolite. Hepatocolite is another entity where the stone liver, there is intrahepatic biliary is full of stone. You cannot remove all the stones. So you have to adapt, or you have to take help of another procedures. Deformed duodenal valve. Deformed duodenal valve sometimes because of gastric outer obstruction. Still, you can do it by dilating the duodenum with a balloon. We do it, but for the beginner, it is not possible. Now let's come to another entity. We most often nowadays we get stoned both in the gallbladder and bile duct. Then what is the option for the students? If somebody asks you what is the option, your answer should be if the facilities are available, ERCP first, then lap cholecystectomy first. Second option, it is open CVD explosion and cholecystectomy. Third option is if the facilities are available, operative lap CVD explosion and cholecystectomy. So these are the 3 or 4 options. So you have to answer according to your situation, or according to the procedure available in this our country or worldwide. Initially, after the introduction of laparoscopic cholecystectomy, the laparoscopic surgeon challenged the role of ERCP, and they started doing lap CVD explosion. But I have seen many experienced surgeons do lap CVD explosion, but they are not satisfied because patient has to come to the intervention endoscopist if anything happens. So ERCP has returned to its original state pre-laparoscopic era, that is, all CVD should be managed pre or post-operatively by ERCP. But if anything happens like that, you are doing laparoscopic cholecystectomy, before that doing your surgery, there was no mention about this CVD stone. But if you think that there is stone, and if you have done paraoperative coloniogram, you found a stone in the bile duct, then facilities are available. That is, facilities means I want to mention 2 things: paraoperative coloniogram is the facilities, or paraoperative cholecystectomic facilities. Then you can only handle the you can do lap CVD exploration. Otherwise, you should not do it. You should keep it for subsequent ERCP. Residual stone. This is a very important area, because we are doing surgery unknowing that there is a stone in the CVD, or sometimes even doing CVD exploration. Even for experienced surgeon, we can lift some stone in the bile duct, not intentionally, but it happens. It is the reality. It happens. It is written in the book. It will happen in future also. So the problem is ERCP, because surgery is not possible. You have done surgery for a patient, you cannot go for re-exploration of the bile duct repeatedly. So empathetic doctor, that is consultant, should be very much empathetic to the patients to make them understand that what is the what's the thing happens and what is the solution. So residual stone usually it's presents with postoperative bile leakage, or it detects after T-tube cholangiogram, or months or year after cholecystectomy by doing ERCP, and after CVD explosion. So residual stone is a big problem, and most of these stones are overlooked stone which migrate from the gallbladder. So here just I have mentioned, I have showed you this on video clips of one problem. The patient, you have this patient have residual stone with T-tube, but the problem is that even for us old people, it is also difficult for us. You see, this video is not moving. So this is the video clip not playing. This patient had a CVD stone. I attempted to remove the stone, having T-tube in situ, but I grasped the T-tube with the basket. But it is very difficult to disengage the basket from T-tube. So the suggestion is, if there is a T-tube, go for tracheotomy and put a stent, remove the T-tube, then go for basket sweeping. It is safe. And another entity is hepatocolithiasis. This is a big problem. Nowadays, because of MRCP, we get lots of patients having a stone inside the liver. So solution, if it is confined to the single duct, single stone, even only left duct or right duct, single or 2 to 3 stone is possible. But multiple stone is not possible. You have to take the help of cholecystoscope. Otherwise, it is not possible. The daughter cholecystoscopy is available, so intrahepatic stone removal with the, if you want to do interventional endoscopy, and actual solution is about jejunostomy after cleaning all the stone, because this is a very challenging area. where endoscopist has very little role to play. Next entity is malignant biliary obstruction. As you all know, the obstructive jaundice due to any malignancy, particularly its outcome is very poor, and curative resection is possible only to 15 to 20% of the cases, particularly in ampullary carcinoma, not for lower cholangio or carcinoma metabolite case. So it is the statistics from not from our country. It is the statistics in a textbook. But in our country, scenario is very worse because we get all the patient very late. So in my experience, I have seen that even periampullary carcinoma, only about 5% patients when come to us, it is operable. Rest of the patient, that is 95% patient with malignant biliary obstruction is inoperable. So choice is ERCP. So indication of ERCP, if you want to do, one is preoperative major pruritus, cholangitis, or patient is not fit for surgery. And palliative when inoperable patient for pruritus and cholangitis. So in my experience, in hepatobiliary surgery, malignant obstruction, it is 95% cases you can palliate the patient with doing ERCP. So for the student, I have added few video clips just to make them so that they don't feel bored. So this is a plastic stent. Even higher cholangiocarcinoma, you have to put a stent in the both left and right duct. It is sometimes possible in the left and right duct, you can go for plastic stent. But if it is below the level of higher cholangiocarcinoma, it is usually for malignant biliary obstruction to put a metallic stent, because you cannot go for plastic stent repeatedly. So if you put a metallic stent, till death it will persist. Today's evening, I have done one case. They have done ERCP in India, and I have replaced the plastic stent with a metallic one today evening. Next, another issue is the bile duct injury. Bile duct injury, option is 2, endotherapy and surgery. Nobody will accept you. The patient will not accept you because they have come for a benign disease and you have done bile duct injury, which is more serious than that of the malignant biliary obstruction. Patient suffers throughout his life because of the consequence of bile duct injury. So after introduction of the laparoscopic cholecystectomy, it is an observation from all of the world that incidence of bile duct injury increased. And not only that, the injury level of injury is higher, because bile duct injury, what happens, as you all know, we first divide the common bile duct, then we dissect, and we then divide the common hepatic duct. So there is a segment loss. First we cut the common bile ducts, thinking that it is cystic duct. We proceed the dissection, and finally when we cut another duct, then we detect, oh, we have done a bile duct injury. So this is segment loss, among high up injury. It is very dangerous. So the ERCP expert will classify the bile duct injury in the Bergman's classification. Bismuth usually for the stricture, for that is reconstruction. For Bergman's, that is for bile leakage. You see here type 1A, A1, A2, and with these three entity, that is cystic duct leak from the accessory apparent duct leak or from the partial injury, we can pinate this patient by doing ERCP and stenting. But for other types, that is type C and D, it needs surgery. So you think these are the things we can identify by doing ERCP. So this is bile duct injury, ERCP and stenting. Mostly we use plastic stent in case of biliary injury, so for small leakage. So biliary ascaris. Next issue is biliary ascaris. The most common ailments in human GI tract. We get lots of the patient from this Dhaka-Chittagong highway, particularly in Kusti, Kumilla, Noakhali. In this belt, I don't know why this belt is patient is lots of patient we get from, or maybe from good communication or their hygienic condition is not, whatever may be the cause. We get lots of patients from this belt. It is an important cause of hepatobiliary disease, and diagnosis is usually done by ultrasonography. ERCP, we do it only to prevent complication. You must keep in your mind the biliary ascaris patient usually presents with sudden severe agonizing abdominal pain. That pain mimics to acute pancreatitis. So you have to diagnose it. You just do simple ultrasonography, that will say there is a worm in the bile duct. Don't go for ERCP in the first instance, because most of the cases, 95% of the patient with worm they expel spontaneously. Do not need any intervention. And don't go for surgery, go for God's sake, because once it happens, that patient develops recurrence again and again. So don't go for better do for dehelminthic, that is antihelminthic drug to the prescribed to the patient. Don't go for open surgery for bile duct worm. So ERCP, 1 to 2 days you wait. If this the worm is dead, it does not expel spontaneously, then you can go for ERCP. So this was one of my the earliest, I think in 2004. This is one of the oldest collection. You see there is lots of worm in the bile duct. Altogether, 23 worms were extracted from on this single patient. So you can imagine the incidence of biliary stone. Here you see this another example of biliary ascaris, which sometime in theory book you see that the stone, that is worm acts as a medius for stone formation, but here you see that worm and stone are coexisting in the same patient. So it can get this type of patient also. Endotherapy for pancreatitis. Now, acute pancreatitis, chronic pancreatitis, and post-traumatic fistula. There are three conditions where we go for ERCP. Now, in my at the beginning of my talk, I have mentioned that this ERCP is contraindicated in pancreatitis, but in one area. One area in acute biliary pancreatitis, if it is due to stone impaction, that is gallstone pancreatitis, ERCP is mandatory. This is the only solution. You see, what is the pathophysiology student? You see that how this biliary pancreatitis happens. You see this bile duct and pancreatic duct, regularly the secretion is going to the duodenum, but patient having gallstone, and for some reason contraction of the gallbladder causes the migration of the stone from the gallbladder to the bile duct. And in the bile duct, this ampulla is the most narrow part. It gets impacted in the ampulla. What happens? The retrograde flow of bile upwards, obstructive jaundice, and pancreatic enzyme blockage activating the pancreatic, that is pancreatic enzyme, leads to acute pancreatitis. So solution is just even if you don't go for ERCP, you just go for a pre-cut papillotomy. Just impact a stone in the ampulla, you just make a small incision, disimpact the stone, the patient will improve dramatically. On the same day, patient will improve. There is no pain, there will be no pain, nothing. Patient improve dramatically. So you don't have to put dye in the bile duct. You don't have to do a formal cholangiogram, because MRCP have shown you that there is impact in the ampulla, but you have used the all ERCP instruments. So this is ERCP, not out of it. So this is the only indication for doing ERCP in acute pancreatitis. Let's come to the chronic pancreatitis. This pancreatic endotherapy. It is difficult from biliary endotherapy because technically it is more demanding, and result is not always satisfactory as that of open surgery. So as you know, chronic pancreatitis actually it is a multidisciplinary approach. Surgeons, medical personnel, endoscopist, everybody should involved in this in the management of chronic pancreatitis. Definitely surgery is the gold standard, but what about endoscopy? It is less invasive. Result is comparable to the surgery, and surgery you can do surgery even after failed endotherapy, but after surgery, the role of endotherapy is very minimum. So but after the endotherapy, surgery you can do, but after surgery you can do go for it. So this is a very important area. So regarding outcome of the surgery, it is not always good. I should say nobody can remove all the stone, and the change that occurs in the pancreas, it is not reversible. So even after surgery, patient will some of the patient will improve. So for the student, if you know the pathophysiology of acute chronic pancreatitis and you can break the cycle, patient will definitely improve. So if you just consider the cycle of pancreatitis, what is chronic pancreatitis? Anyhow, if there is obstruction in the duct by stone, stricture, or plaque theory, whatever, maybe there are lots of theory. I'm not going in details of the theory. That obstruction, what is the consequence? This is the ductal hypertension, and this is tissue hypertension. And this duct, when the ducts dilates, surrounding tissue gets ischemic, leads to pain. And this ischemic tissue This is secondary obstructive chronic pancreatitis, this parenchymal atrophy that causes both exocrine and endocrine deficiency, ultimately malnutrition. So if you can relieve this obstruction, what we do by surgery, we call lateral pancreatitis. Just even if you don't remove the stone, just do a bypass surgery, then the patient is improved. What is the rationality of that surgery, that the improvement? It is the relief of obstruction. So we can relieve this obstruction. You see here, ERCP, by ERCP, you can relieve the obstruction. This is the dilated pancreatic duct. Just we have negotiated the pancreatic duct with the guide wire, then opacify the duct, and after opacification, you just put a simple stent that relieves the obstruction, and we can keep the stent for 6 to 8 months or 3 maximum. Initially, it would be fixed for kept for 1 year, but now the AIGS, they has changed their protocol. 6 months, after 6 months, they change the stent. So repeated re-stenting that solves the problem. Ultimately, this obstruction leaves. Sometimes the stone is very soft. You can remove the stone. You see that soft stone. You can remove the Dormier basket. Dilated duct. The whole duct is dilated. You can remove it by Dormier basket. So pancreatic endotherapy is now a evolving subject worldwide. They are doing lots of work on pancreas, particularly those who have got the ESWL facility, because whatever be the size of the stone number, you can pulverize the stone with the ESWL, then you can remove it, and after that you should put a stent, and there is free flow of pancreatic juice after putting a stent. So and ERCP has a tremendous role in the management of chronic pancreatitis. Regarding other indications, there is one indication I should say is you will get lots of patients having dilated biliary tree, no stone, nothing, no malignancy, but there is narrowing at the ampulla. So we call it functional papillary stenosis. Functional means there is no organic lesion, no growth, no stricture. Functional papillary stenosis may sometimes you might get the biliary dyskinesia and other things, dilated bile duct, and patient suffers from biliary colic. Though we don't have the facilities of measuring the bile duct pressure by biliary manometry, still then simple functional single papillotomy, you can solve the problem. So now I'm nearly at the end of towards the end of my presentation. Then let's come to the complications. Post ERCP pancreatitis, this is very dangerous complication, I should say, because in general pancreatitis has got a morbidity and mortality, but ERCP has got more. And gastrointestinal bleeding, actually this bleeding happens after papillotomy. A conventional papillotomy does not cause any bleeding, but pre-cut, during pre-cut, if this cut is from the normal usual site, then the chance of bleeding, but usually stops. Or we can stop it by doing maybe different maneuver. And infection, that is cholangitis and cholecystitis. Cholangitis is very important, particularly in case of malignant biliary obstruction. In this sorts of patient, if you cannot drain the bile duct properly, then this patient, that is, if you put a plastic stent, narrow stent, there is every chance of cholangitis. If you can put a metal stent, chance is very less. If somebody develops cholangitis, malignant patient, septicemia, death is inevitable. Viscous perforation is very rare, but still it can happen in malignant patients. So I'll say a few words regarding the post-ERCP pancreatitis, because in which patient it will happen, it is very difficult to predict. Still then, we take some measures, but like pre-operative, we give some drugs that reduce secretion, that is mucomist, there is some preparation. We give the tablet, and even we give indomethacin suppository during the procedure. Even after procedure, diclofenac sodium we can use, but indomethacin 100 mg is recommended. Even after the procedure, if you feel, we actually preventively or prophylactically start that is hydration, proper hydration, everything till before getting the lipase report. You can predict which patient can develop ERCP, because you have done ERCP subsequently, repeatedly you have entered the pancreatic duct 3, 4, 5 times. You have opacified the pancreatic duct. Definitely you have to take precaution beforehand. So there is risk of post-ERCP pancreatitis, young female patient, cannulation difficulty, inexperienced operator, history of previous ERCP pancreatitis, and pancreatic division. These are the few conditions. This is not for the students. This is for the faculty members. And now let's come to the how can we prevent. Actually, it is very difficult to predict which patient will develop pancreatitis, but it is better to predict. It is better to take precaution and be a few rules of ERCP. There, I should say, there are some rules. That is, you know your patient. That is, what are the indication? What is the anatomy in MRCP, previous ERCP history like that, and you should have all instrument in your hand. You should have all instrument in your hand, and lastly, prevention of pancreatitis. There is certain rule, you cannot attempt for more than 5 minutes, 5 attempts, and simple condition in the pancreatitis once. It is very difficult, and you must know when to stop. You cannot do ERCP. You cannot do ERCP for hours together. You have to stop somewhere, because they are already approached. If you think that I have failed to do ERCP, who will go to help the patient? No, there is other people are there. They will help the patient. So you consider alternative approach. These are the approach. If you fail to do complete intervention, then you go for endobiliary stent. You can put nasobiliary stent. You can go for percutaneous approach. You can refer the patient for surgery. Even you can refer the patient to higher center, those who have experience of doing complicated, difficult ERCP. So in conclusion, I want to mention one thing for our student, the overall success, because we are doing intervention. If there is success rate is not comparable with the other procedure, why people should go for ERCP? In my experience, till last month, I have done 7,300 therapeutic ERCP. Of them, it was 92%. It was successful in stone disease. 91.7% it was successful in malignant disease, and bile duct injury 63% less, because I did ERCP stenting for selective cases. In Boswell classification BC, I did not do any intervention. It was just for diagnostic. And lastly, chronic pancreatitis, this 83% is exaggerated, I should say, because here I also did only selective patient where I can do ERCP extraction. I did it. All patient I did not attempt for chronic pancreatitis because all patients are not suitable. Hepatolithiasis, out of many patients, I did only 20% cases to remove the stone, and functional papillary stenosis, it was possible 100% cases. So in these few words, I again thank to the organizer, particularly Professor Khandar Azad and his excellent team for giving me the opportunity to share my experience with the student. Thank you, everybody. That is, I feel free to answer any question from the audience, students, or any clarification.
Okay, thank you very much, Professor H.M. Tawhidul Alam, for your brilliant presentation. Almost you have covered the whole hepatobiliary and the pancreatic disease where the ERCP can play an important role, and how to navigate these ERCP procedures to these hepatobiliary pancreatic diseases. It's a brilliant one. And finally, you have shown also your personal experiences, which is also a very brilliant one. So এখন দেখি আমাদের স্টুডেন্ট যারা আছে ওদের মনে নিশ্চয়ই অনেক কোশ্চেন থাকবে, তো আমরা কিছু কোশ্চেন নিয়ে আলোচনা করি। আমি কি স্টপ করব আপনারটা?
Please.
Sure.
Please.
Now question answer sessions. Any question from our students, please feel free and ask any question to our speaker and any faculty member. Please feel free. Any students?
Sir, assalamu alaikum.
Bolo.
Sir, we know that we do ERCP for therapeutic purpose, but my question is still, is there any condition we do ERCP for diagnostic purpose?
No, there is no single condition. Because ERCP is not a safe procedure. Because in my experience, if I tell you, the complication that happened in my hand, all are diagnostic. But there was no absolute indication. I was bound to do by the request of seniors or other people, and it was most of the complication happened with me in my early part of my career. For the last 10 years, there is no pancreatitis.
Okay, fine. Any question? Any students?
Sir, can you share any disastrous complication or any type of complication have you ever faced during proceeding in ERCP, sir?
In your life, Tohid bhai, bolo.
It is during ERCP or post ERCP?
Both.
Your overall experience.
Overall experience, if you say, I did duodenal perfusion in two patients. One patient was 95 years, I think, female patient. It was related to B. Hassan Chaudhary, Silet, his relative, and he referred the patient to me. This is an elderly patient. It is not possible to do open surgery. Please help him. And there was a periampular diverticulum. I attempted. I tried my best. I thought that if I cannot do it, who is going to do it? This is not very dangerous attitude. One should not do it. If you cannot do it, abandon it. But that ego actually, Dewan is there. He is the muted. Dewan Hassan, he can remember, I think. And actually, elderly patient is there. They do not. The intestine also wall becomes thinner. Peritoneal fat, everything, tissue become more fragile, more vulnerable to injury. So whenever I want to do this maneuver in the duodenum, just to make the fiber straight. Usually we enter into the third part of the duodenum in a tortuous course, in a long course. Or before starting therapeutic intervention, we make the fiber short. That is, we make the fiber just straight like a hockey stick. And when I wanted to short the fiber, somehow this angulated fiber tear the duodenal wall and duodenal perforation. And I had to do laparotomy. I had to repair the perforation. I had to explore the CVD. The patient survived, no problem, because with the surgeons. Complication happens, but with the surgeons, as I mentioned earlier, that you have the preparation of the patient before ERCP as that of the open surgery, or like that of the open surgery, because who knows which patient will behave how. So you must prepare yourself, your mind and yourself, that any patient can need surgery, and the patient improves well and went home uneventful.
Okay.
And post ERCP pancreatitis in the Chittagong, I think one of the relative of Dr. Chittagong Medical was his sister-in-law, I think they have developed acute pancreatitis in the early part. He suffered a lot, ultimately improved.
Okay. Okay. So total number kota apnara rakhen?
Perforation 2.
No.
Duodenal perforation 2. And pancreatitis, post-ERCP pancreatic death, I think it was not lost the 3 or 4, I think, in my lifetime.
Okay.
For the last 10 years, no. But initially it happened with me. And for your information, many of our surgeons, they have stopped doing ERCP because of this pancreatitis.
Okay. মানে আপনার টোটাল নাম্বার অফ ERCP কত এ পর্যন্ত?
Number 7,300 till date.
7,300. That's great, really great. Okay, any more question? Any more question?
স্যার
Please.
Amin, বলো।
স্যার আমি একটু একটা প্রশ্ন করতে পারি, মানে একটা কেস নিয়ে লাইফ টাইম, মানে একটা কেস নিয়ে একটু কনফিউশন ছিল স্যার। স্যার থ্যাংক ইউ স্যার for giving me opportunity, sir. I am now working as a medical officer in Kuwait Mufti Government Hospital. In last month, we had gone through a laparoscopic cholecystectomy, which was difficult, and after that, we have to convert it to open, and we found out that there was a CVD injury. So we did not go for any intervention. Just we kept some drain and closed the patient, and subsequently patient improved. We did MRCP after 1 month, and here they show that there's a distal stricture only, and other than that everything is normal. But the injury was that we found it was in the confluence of the CVD, that means cystic duct connecting to the CVD, sir. And now when to do, my question is that is there any আমাদের কোনো ম্যানেজমেন্টের কোনো জায়গায় কোনো ল্যাপস ছিল কিনা? আর দ্বিতীয় কোশ্চেন, এখানে ERCP স্যার কখন আমরা করতে পারতাম স্যার, বা করব কখন স্যার?
Thank you for your question. Actually, bile duct injury, মানে bile duct injury বলবো না, post-mortem bile leakage বা ইনজুরি ডিটেক্টেড ডিউরিং সার্জারি। যদি তুমি দেখো যে এটা মাইনর ইনজুরি, একটা লিক হচ্ছে, তাই না, তুমি একটা ড্রেন দিয়ে মনে করো তুমি এটা মানে স্টিচ দেওয়া নাই বা তুমি কনফিডেন্ট মনে করা নাই, তুমি একটা ড্রেন দিয়ে চলে আসবে। এখন দেখা যাবে যে আমাদের লিকেজের অ্যামাউন্টটা কমন। ইউজুয়ালি যদি বাইরে একটা ইঞ্জিন হয় তাহলে মোর দেন 500 ফ্লুইড আসবে, তাই না? 500 বাইরে আসবে। এরকম যদি আসে সাবসিকুয়েন্ট এতে যদি কমতে থাকে তাহলে ইউ ক্যান ওয়েট অ্যান্ড সি। যদি তোমাকে বাড়তে থাকে ইউ শুড নট ওয়েট, বিকজ এই বাইল পেরিওডাইটিস একবার হয়ে গেলে এর কনসিকুয়েন্স আবার খারাপ, এটাকে আবার টয়লেট করতে হয়, বিভিন্ন রকম ঝামেলা হয়। তা আইডিয়ালি যেটা আমরা বলি, বাইরে একটু যদি সাসপেক্ট করো, ইউ শুড পুট ওয়াইড ড্রেন, অন্তত 18 সাইজে 2-3টা ড্রেন দিয়ে আসবা, যেখানে যেখানে কালেকশন হতে পারে সব জায়গাগুলো কভার করে দেওয়া আসা উচিত, তাই না? একটা ড্রেন না, তুমি যদি একটা ড্রেন ব্লক হতে পারে, তুমি হেপাটিক যেখানে লিক হচ্ছে এখানে একটা দিলা, প্যারাকুল গ্যাটার একটা দিলা, তাই তোমার দিলা, তুমি পেলভিস একটা দিলে, এইভাবে তোমাকে বেশ কয়েকটা ড্রেন দিলে এই পেশেন্ট সেফ থাকবে। এরপরে যদি তুমি দেখো লিকেজটা ডে বাই ডে কমে যাচ্ছে, শুড নট গো ফর ইআরসিপি। যদি দেখো যে পারসিস্টেন্ট লিক কমছে না, ডেফিনেটলি একটা পেপলোটমিকের স্টেন্ট দিলে ড্রামাটিক্যালি কমে যায়। যেহেতু তুমি দেখছো তোমার পেশেন্টটা ডিটোরিয়েট করছে না, তুমি একটা চান্স দিয়েছো। অ্যাকচুয়ালি ইট ইজ দ্য জাজমেন্ট, ইট ইজ দ্য এক্সপিরিয়েন্স। তোমার সিনিয়ররা হয়তো মনে করছেন দরকার নাই, কিন্তু যদি দেখো যে মেজর ইনজুরি, বড় ডিফেক্ট, এটা আইডিয়ালি আর্লি পেপিলোটমি স্টেন্ডিং করলে রোগী রিকভারিটা তাড়াতাড়ি হতো হয় আর কি।
থ্যাংক ইউ।
তুমি বললা যে পেপিলা স্টেনোসিস, তোমার পরে এমআরসিপিতে যে পেপিলা ন্যারো, তার মানে ন্যারো এটা নর্মাল পেপিলা তো স্পেস্টিক ছিল, দেখার সময় ন্যারো। অনেক রোগী আছে ওই গর্ভধারণ অপারেশন আগে পাঠায় স্যার বাইরে ডাইলেটেড পেপিলা, আমি বলে যায় না, পরে যদি লাগে দায়িত্ব আমার, তুমি গর্ভধারণ করে ফেলো, কারণ দিস ইজ নট প্যাথোলজি, দিস ইজ নর্মাল।
আসসালামু আলাইকুম স্যার। স্যার এই একটা
Yes.
কোশ্চেন ছিল স্যার।
শিওর,
স্যার
বলো।
এই কেসটার ক্ষেত্রে স্যার, এই কেসটার ক্ষেত্রে স্যার আমরা ইআরসিপিটা যদি করি স্যার, সেক্ষেত্রে
হুম।
কতদিনের মধ্যে করবো স্যার? মানে
ইআরসিবি করলে তুমি যদি দেখো যে, তো ইআরসিবি করলে ইউজুয়ালি যদি স্টেন্ড তুমি ড্রেন দিয়ে আসার পরে তুমি একদিন দেখতে পারো, একদিন তুমি 24 ঘন্টা দেখতে পারো যে অ্যামাউন্টটা কেমন আসে। যদি তুমি দেখো যে 500 সিসির বেশি কাটছে, এটা দিয়ে ওয়েট করার কোনো দরকার নাই। আর যদি দেখো 5-10 সিসি আসছে, তাহলে ইউ ক্যান ওয়েট। সফট আছে, আদারওয়াইজ এভরিথিং এভরি প্যারামিটার নর্মাল, ইউ ক্যান ওয়েট।
থ্যাংক ইউ স্যার।
Okay. Any question?
আসলে এই জায়গায় কোনো স্ট্যান্ডার্ড কোনো রুল এভাবে আমি বলবো না, এটা ডিপেন্ডস করে। তোমার ধরো একটা পেশেন্ট, তুমি একটা মনে করবো যে এটা কোমরবিডিটি আছে, এই পেশেন্টের ঝামেলা হলে ল্যাপারটমি করার স্কিল তুমি সাথে সাথে করলেই বেটার, তাই না? আর যদি মনে করো যে না, পেশেন্ট ক্যানট অ্যাফোর্ড, বা আমার মনে হয় এটা ইমপ্রুভ করবে, আদার কোনো ইয়ে না, তো ওয়েট, এটা ইন্ডিভিজুয়াল পেশেন্ট হিসেবে তোমাকে কনসিডার করতে হবে।
জি জি। Okay. Okay. Thank you. Any more question from students?
আমি কিছু কমেন্ট করতে চাচ্ছি, বলবো?
আমরা
শহীদুর রহমান বলছি।
Sure, বলেন।
নাইস প্রেজেন্টেশন, থ্যাংক ইউ ভেরি মাচ।
থ্যাংক ইউ।
কথা অ্যাড করি আমি,
প্লিজ।
এবং তুমি বলেছো যে ইম্প্যাক্টেড স্টোন at the ampulla bed causing acute pancreatitis. Pathogenesis is like this. Actually, pancreatic enzyme in the main pancreatic duct remain in the inactive form. When there is stone impacted the ampulla, there is reflux of bile into the main pancreatic duct, causing these inactive pancreatic enzymes become active and causing harmful destruction to the pancreatic parenchyma. That's why there is acute pancreatitis. Number two, in case of chronic pancreatitis. In case of chronic pancreatitis, what happens? Multiple stones usually causes obstruction, and there is intraductal hypertension is the main cause for pain in the chronic pancreatitis. And other two components, but very less significant, like psychogenic and neurogenic, but less significant. Main cause for pancreatic pain in chronic pancreatitis. So we are very much as you everybody all know about my recent techniques, interduct from head to tail. When it becomes dilated up to 5, 6, 7, 8, 9, even on centimeter sizes. Common ductal diameter is in the head millimeter, in the bottom millimeter, in the tail 1 millimeter. This is the normal size. normal diameter MPD. But when a stone impacted and there is multiple stones, then some causing severe patients remain hospitalized, medicine through.
হ্যাং হয়ে গেছে মনে হয়
না আপনার ইয়েটা সাউন্ডটা মাঝে মাঝে ইন্টারাপ্টেড হয়ে যাচ্ছে।
আচ্ছা ওকে আমরা নেক্সট কমেন্ট নেই প্রফেসর হাসান দেওয়ান হাসান চৌধুরী হাসান শুনতে পাচ্ছ হাসান আমাকে শুনতে পাচ্ছ হাসান নো আচ্ছা
আজব ভাই সালাম
আসসালাম কেমন আছো ভালো
কাজে গিয়েছিলাম শুরুতে ছিলাম আমি আবার কাজ করা শুরু করে দিয়েছিলাম এই জন্য কথা বলতে পারতেছিলাম না
আচ্ছা
আমি শুরু এনজয় করতেছি
হ্যাঁ হ্যাঁ ওকে এনি কমেন্ট বা অ্যাডভাইস টু
করবো যে আজ তৌহিদ স্যার যখন আজ ওদের আসেন আমি মনে করি যে যেভাবে ট্রেনিং দিয়ে যাচ্ছেন যারা স্টুডেন্ট এরা পাশ করে ওরা জন্য যারা সরকারি চাকরিতে যেখানে থাকুক ওরা শুরু করুক আসলে এটা আমাদের এই সাপোর্টটা যেমন ইন্টারভেনশনাল কার্ডিওলজি ওরা যদি করতে গেলে যে এবং এই সিএজি করতে গেলে যেমন ব্যাকআপটা দরকার যে কার্ডিয়াক সার্জারি তেমনি আমরা যারা এই সার্জারি করবে তাদের এই ব্যাকআপে তার জন্য ইআরসিপি করাটা অনেক কনফিডেন্টলি তারা করতে পারবে এখন যারা স্টুডেন্ট পরীক্ষা তো আর পাস করবে পরীক্ষা করবে কিন্তু পরবর্তী আমাদের এই টার্গেটটা রাখে যে যেখানে সরকারি চাকরিতে থাকবে ওইখান থেকে শুরু করুক তারা
জি রাইট
থ্যাংক ইউ
Malum sir will you make any comment and advice to students স্যার কি আছেন শুনতে পাচ্ছেন মালগুম স্যার শুনতে পাচ্ছেন আমাকে
তো ছিলেন এতক্ষণ এখন তো দেখছি না
ছিলেন তো আচ্ছা আচ্ছা ওকে ফাইনালি very good presentation এবং interaction with the students ERCP main কথা হচ্ছে it's now no more a diagnostic procedure it's a therapeutic procedures এবং স্টুডেন্টদের আজকে যে ক্লাসটা হয়েছে এটা আমরা খুব শীঘ্রই আপলোড করব তো এখান থেকে অনেক ইনফরমেশন তোরা রিভিউ এবং রিক্যাপিচুলেট করতে পারবে তো ফাইনালি তহিদ ভাই আপনাকেই বলি জাস্ট টু গিভ সাম টেক হোম মেসেজ ফর দ্য স্টুডেন্টস
আমি যেহেতু স্টুডেন্ট আমি স্টুডেন্টদের জন্য বলবো যে আমরা এখন যে পরীক্ষা টরীক্ষা গুলো হয় আমাদের অনেক সার্জনরা কিন্তু এন্ডোস্কোপি ইআরসিপি ওইগুলো করছে তার মানে আমাদের কাছে যখন কোশ্চেন যাওয়া হয় আমরা কিন্তু মেটেরিয়াল পাঠাই তো তোমরা ইউ শুড রিমেইন প্রিপেয়ার্ড যে তোমরা একটা এমআরসিপি ফিল্ম বা একটা এমআরসিপি তে দেখা গেল যে সিভিডি স্টোন গল স্টোন রয়ে গেছে হাউ ডু প্রসিড তো এগুলো যে কথাবার্তা বলা রেশনাল কথাবার্তা বলে এগুলো প্র্যাকটিস করতে হবে তাই না তারপর বাইরের একটি জুড়ে ছবি থাকে এমআরসিপি থাকে বিলিয়ারি স্ট্রাকচার ম্যাগনেট বিলিয়ারি স্ট্রাকচার হাইলাইট কলমোকার্সিনোমা বিভিন্ন ছবিতে কিন্তু থাকে এখন এমআরসিপিতে সিটি স্ক্যানের ফাইন্ডিংস থাকে একটা গলব্লাডার নিউপ্লাজম আছে এতটা সিনারিও থাকবে তো এগুলো আজকের ক্লাসটা নেওয়ার উদ্দেশ্য যে এগুলো তোমাদের ইআরসিপি করতে হবে না শেখার এই মুহূর্তে দরকার নাই কিন্তু তোমার ওরিয়েন্টেড থাকবে যে ইআরসিপি রিলেটেড যদি কোনো কথা যে পোস্ট ইআরসিপি প্যানক্রিয়াটাইটিস হাউ ইউ ক্যান প্রিভেন্ট ইট তাই না প্রিভেনশন তো তোমাকে জানতে হবে তুমি তো মেডিকেল অফিসার না তুমি তো যারা সেকেন্ড পার্ট পরীক্ষা তোমরা তো একটা রেজিস্টার বা আরো সিনিয়র লেভেলের চাকরি করছো এখন তোমাকে প্রিভেনশনটা জানতে হবে তুমি ইআরসিপি প্যানক্রিয়াটাইটিস হলে তো আলাদা ইস্যু কিন্তু তুমি যদি ইউ ক্যানট প্রিভেন্ট ইট দেন প্রবলেম এই ধরনের আর কি তোমার পরীক্ষার জন্য এ থেকে এই আমার প্রেজেন্টেশন থেকে তোমরা যেটুকু মনে করো যে তোমার পরীক্ষার দরকার এগুলো তোমরা আমি পিক আপ করলে আমি খুশি হব তাহলে আমার শ্রমটা সার্থক হবে এবং ওইভাবে তোমাদেরকে প্রিপেয়ার করবো ধন্যবাদ সবাইকে
থ্যাংক ইউ ভেরি মাচ আজকে আমরা মানে অনেক আলোচনা হলো এখানেই শেষ করছি থ্যাংক ভেরি মাচ প্রফেসর হাসান Professor Shahidul Rahman, Professor H.M. Tohidul Alam, and Professor Margu Bhushan for joining us today, and other faculty surgeon jara chilen teachers. So thank you all, and dear students, see you abar Mongolbar dekha hobe inshallah. Till then, stay safe, stay blessed. Thank you, Tohid bhai. Thank you.
Most welcome. Thank you.
আসসালামু আলাইকুম স্যার
Ji, Assalamu alaikum.